It's 7 p.m. Central European Time. Hello, everyone from Lignano near Milan, Italy. I'm General Danna. I'm a neuroradiologist at ISST West Milanese in the northwest of Milan, and I'm very happy to be this evening with all of you to moderate and co-moderate this last webinar of AI in clinical practice by European Society of Medical Imaging Informatics. And I'm very happy over the speaker to have with me as a co-moderator Pnar Yilmaz from Erasmus University. But before to give the virtual microphone to Pnar, please give me just a couple of seconds to say thank you to Bayer to supporting us in this wonderful educational initiatives. So by me, Pnar, the virtual stage is yours.
Thank you very much, Gennaro. It's a pleasure to introduce Professor Wiest from the University of Bern, among a lot of things that he does as a deputy director, a medical director, a research director of the Support Center for Advanced Neuroimaging. He's also co-director of education for the Center for Artificial Intelligence in the University of Bern. And among a lot of things, as I said, he has over 400 published articles, 26 book chapters, and a lot of citations that we admire. So I want to give the floor to Professor Wiest today to inform us about the monitoring of artificial intelligence within clinical practice. So the floor is yours, Professor Wiest.
So, dear colleagues, thank you very much for this kind introduction. These are briefly my disclosures. And I would like to start with a more general view on the topic. Since all of you know, there has been a tremendous evolution throughout the last 30 years in techniques related to artificial intelligence. And methods have become much more fine-grained over time, but this came along with some problems also, because when we started with a simple rule and knowledge-based system, there were these simple kind of if rules that were easy to tackle and easy to follow by humans, and we could easily understand this kind of methods. In the next generation, when we came into feature engineering, we still had the possibility to retrieve at least kind of features out of the models in order to understand what is the main driver of decision-making in this kind of modeling. But with the neural network approaches, I think these methods became more and more black boxes. And this kind of evolution of black boxes has challenged us as clinical neuroradiologists in order to try to make the best of it, to interpret and also to understand these models. I think one of the crucial points that we need to have a closer look at is the data quality. And I will briefly try to show this throughout this talk. The other ones is to monitor the performance of the model, but also to see if the model itself is confident on its own decision-making. If you are using methods in clinical practice, you usually tend to identify and to buy these kind of tools. So either you want to have something that alerts you for decision support. Many of you use this kind of technologies for doing image quantification, for example, in multiple sclerosis or in quantifying atrophy. And some of you may also think about having these methods for computer-aided detection in order to find a lesion that may be otherwise overlooked. The field of computer-aided diagnosis is still in its very beginning, and in the most clinical scenarios, it has not a very strong place at the moment. But I think this is just an overview, and I'm working in the field of neuroradiology, so I selected some topics that come out of my personal field, but you have for decision support usually tools that help you at the point of care to do immediate diagnosis. You have systems for detections, especially if you're not very, let's say, in-depth specialized in some things that may help you to identify, for example, aneurysms in order to avoid that there are false negative results. Or you go for computer-aided detection in large vessel occlusion. But I think the majority, at least in the field of neuroradiology, is still related to the depiction of lesions in the white matter in the brain and to monitoring of brain atrophy. And this also, I think, opens this kind of first question: how can we monitor these systems? And of course, we can do that in a daily workflow. Look at the acceleration that is coming along with the implementation of an AI tool. Are the processes going faster? Are you getting earlier to make a diagnosis? There is, of course, the investigation of the detection rate of the accuracy, but nevertheless, it's also important to ask about the robustness of this kind of models. I've stratified my talk into 3 different topics. The first related to the parameters, meaning how can we do image acquisition and what do we need to take into account in order not to be incorrect in the measurements we take. The second one is related to our own human perception and perspective. We as humans are prone to errors. And where can these kind of tools help us to get better? And lastly, we could have a short look into data modeling and see what is about data representation and what's about uncertainty depiction. So how do the models tell us themselves if they are sure or not sure with a diagnosis? And I would start with a very simple example that I would like to share with you. I think many of you that use artificial intelligence technologies use these kind of methods, for example, for quantification of brain volume. You can see the output of these models is really good. So there are several tools on the market that show you, for example, the distributions of brain atrophy. They also show you the longitudinal progression of brain atrophy, but sometimes it may happen that you see something that is really surprising. And I would like to show one of these cases with you where we had a patient that was followed throughout 4 different times. Then he got infected with COVID. And during the infection with COVID, the volume of the brain decreased rapidly. Now, it decreased in all of these 4 measures, but if we look at the ventricular size, for example, this was not visible. So what happened? So it simply happened that the patient was monitored at a different scanner with different parameters. And this is, I think, the first take-home message for today is I want to emphasize the role of really being under control about the parameters that have been used to monitor the patients with these tools of artificial intelligence. So something that we did is we calculated the simulated contrast of different sequences versus the real measured contrast. We had 2 volunteers. You can see over here that were repetitive scans in these volunteers. And then we calculated the simulated contrast for different MR parameters. And what you can see over here, that is the impact of the contrast on the measured cortical gray matter volume if you change parameters like the time of inversion, for example. The lattice relaxation is a constant, but also the TR. If you change this kind of parameters, then you get entirely different measures of the brain volume than would be expected if you scan the patient only with 1 sequence. So does it matter? And the answer is yes, because normally if you scan a patient on the same scanner, the test-retest reliability is very high. So it's roughly 0.5% for the gray matter volume. But if you change the protocols, then you end up in 2.5% changes, which is far beyond the measures that you would expect for normal aging. So one of the first, I think, really practical approaches is just to take monitoring of your longitudinal measures. And that's something that we did over here. So these are the protocols that are driven just by clinical consequences. So if there is no space in one of the scanners, you bring a patient to another one. But for longitudinal monitoring, you should be aware that any change, not only between the field strengths, but also between the time of inversion, so that the sequence changes may have a tremendous impact on the quality of your measures. And just to put an example out of here, you can see that this patient has been measured at very different measuring points. And here you can see the impact on the measured volumes. So monitoring the application and the sequences where these patients have been examined is one of the first crucial points. If we look a bit into literature, and I want to cite this paper that has been published last year that examined 17 different CE mark tools, you see that many of these tools have been validated technically, but this in-use validation that exactly takes into account these kind of measures is frequently not done. And therefore, for longitudinal monitoring, this kind of quality assessments are mandatory in order to secure that the measures that you get are really reliable. Now, the next step that you can do is the retest variability testing. So usually you can use mean reproducibility error measures if you scan the same subjects 2 times, or if you just simply repeat one sequence 2 times once the patient is in the scanner. And these kind of measurements, they should not really exceed 0.5% in order to give reliable predictions about the progress in brain atrophy. And you can see we did this with a model that we have devised on our own that has been trained on international data set. And if you can see what you can see over here in green, that is the confidence with the relative silver standard, in this case with FreeSurfer. You see there are almost no changes. There's a very good retest reliability for these 2 methods, whereas the third one is less reliable in that sense. And of course, the most important point is to validate these methods independently. So this has also been done on our method that we proposed over here. It has been done by an external group that introduced simulated contrasts in order to measure different models in terms of their accuracy of the measured atrophy rate. And you can see here this almost linear correlations for different changes in the induced atrophy. So always it is the best to have a look at independent validations of this kind of methods in the literature, or even by people that you know and which you cooperate with. The second step that I would like to discuss is also what is the use, what is the what's the benefit of this kind of artificial intelligence technologies. And for that, we should go a bit into our own competences. That means into our own domain knowledges. And all of us know that we are prone to error, mainly to perception errors, and also something that's called satisfaction of search. So you're confident with the first finding, and you may overlook a second one. And there is kind of artificial intelligence tools that can really help you to get aware of something that you usually might miss. And it's not a problem of our eyes, because the resolution of our eyes is fair enough to depict this kind of lesions. It's a problem with our mind itself. Usually, if you use an algorithm, so you first formulate a medical problem, then the algorithm is trained to depict the relevant features, and then at the end it comes out with inferences. We as humans, we use 2 different ways of thinking. The first one is using what's called heuristic, which is simply a shortcut from something that you have learned during your training, or you have the ability to go into analytic processes. That means to actively reason about your decision. And our brain, in that sense, is rather competent to use both of these systems, and both systems are topographically also distinct. So the way that you use, or the brain pathways that you use for heuristic processing, is different from the one that you use for active reasoning. And this is something where you can really try to investigate the added value of artificial intelligence technologies if you're aware about this kind of biases that you have. So AI may support this kind of cognitive debiasing that is related to anchoring. So you stay with your first conclusions. You usually tend to have this kind of confirmation bias. It means you seek for evidence to justify your decisions. And of course, you're much better in retrieving information that you have recently seen or recently learned. So the algorithms themselves may help to debias your decisions, and we can also systematically investigate what's the benefit of this kind of debiasing. And I just would like to introduce one tool that we have recently introduced. It's a tool for segmentation of hippocampus that uses a simple radiomic output. So it's a surface to volume ratio. It has been trained on a lot of healthy controls and a lot of epilepsy patients. And the goal of this tool is simply to inform you about the surface to volume ratios of the hippocampus and the volumes. So what you can do is you can look at the power and the discriminative power of the method itself. So you can look at the method and see if, in comparison to other comparators in the field, the effect size increases. That means if the model is better in depicting the task that you assign to this kind of model, in this case for identifying volume atrophy or temporal hippocampus atrophy in comparison in patients with this certain subtype of epilepsy, in comparison to healthy controls, but also in comparison to other epilepsies that you would not expect that they exhibit the same volume changes in the hippocampus. But I think the most important one here is to ask, what's the individual diagnostic improvement? And we did a study with 6 different raters where we used ultra-high field MR as a reference, and we looked at the performance of these raters if they have been informed by the models, if they get better or worse, and if also we had a questionnaire, if the mean confidence increased by using this kind of technology. And as you can see here, the majority of these raters improved dramatically when they used the method, and the examinations were done 2 months in between. So there was no memory about what they have seen before. I think the next step to monitor this kind of models, of course, is to see if they have an improvement in the daily and the individual diagnostic performance. Now, the third step, I think, is the most difficult one. It's related to the knowledge about how sure is the model to make depictions and how good does the model represent the data. And we did a survey some years ago where we asked 100 radiologists what they would like to see. The majority said, well, we would like to have either a visual cue that tells us where the model is looking at, or at least the information that reflects the feature, or in the best case, a concept that can be understood by humans that tells us what the model has made as a decision. And I think there are different methods in the field. One of the famous ones is the one that depicts this kind of visual cues. So it's the one that tells you which kind of areas of the body have been identified as the main features over here. And you can see this over here. It's quite understandable. It's called GradCam, the method, by the way, but it's quite understandable that this is a pneumonia, and the model depicts this pneumonia right as it has learned. But in this case, for example, it's an open question. What is the decision of the model? Because it may have also learned that the severity of the pneumonia is also related to the number of catheters in the patient. So this kind of methods, they show you where the model makes its decision, but it does not tell you something about how the model has done this. So we may, in that sense, depict 2 different ways of understanding. It's the interpretability, that is understanding the mechanism behind. And the other one is the explainability, which just tells us at which point or where the algorithm came to the decision. I think some things that are better to interpret is, for example, the probability, how a model makes a decision. For example, if it assigns a certain voxel to a certain tissue class, like, for example, here, the gray matter, or the more complex models that are trained on multiple simulations that provide you with this kind of uncertainty maps that tell you where the model itself is uncertain and where you may have a second look in order to be sure that the model really did a good job in depicting this kind of lesions. It can also be done in a more simple way, and we are again in the field of multiple sclerosis imaging, where we want mainly to know if new lesions arise, or if this kind of new lesions are related to, or if lesions are related to slow progression. And there are also some attempts out in the field. One of them is also to provide the uncertainty by measuring the disagreement of a model with the trained ground truth, and also issuing this in kind of colored maps so that you easily can follow. These are the areas where the model is uncertain. So the model itself is trained during the training to predict when it makes mistakes, and then it outputs this as colored parts of the images. And by that, by outputting this kind of disagreement probabilities, the models achieved a very high accuracy in the depicting of new lesions. Finally, I think that the major question to ask is the model useful or not? And this can, for example, also be depicted by looking a bit more in depth on the features that the model generates. So, for example, you may have a database consisting of imaging data and clinical data. You want to build a model that outputs the probability of a bad outcome, that means deaths or severely bedridden patients, once you perform mechanical thrombectomy. And this can be done by having a look at the features that are provided by the models. There are different approaches. One of these methods is the so-called Shapley or SHAP, the Shapley feature analysis, that tells you what's the contribution of every individual feature of a model in order to predict futile recognition. So for example, you can see here that the most of them are clinical data that we easily understand. Imaging here is only used as one of the parameters. But the open question to ask over here is, if we just use our sheets or just some flow charts in order to depict the risk of the patient, or if we add a more complex model, does the complex model really help in being more accurate in the prediction of the outcome? And some methods that are used over here, that is decision curve analysis that aims at predicting the net benefit of a model. And what you can see here is that at a given probability level of 80%, for example, the initial benefit out in 100 patients for the model is simply 2 other patients, as if you would use a simple model on its own. Now, this kind of methods, they all come with their pros and cons. So the uncertainty describes the level of confidence and helps you to understand how sure the model is. Visualization is nice to see, but there is no return of the feature importance. Feature importance is a very good way to interpret these models, but it's getting lost if the models are getting more concept. And I think the next step to go forward is to investigate the concepts. That means to introduce maybe analysis or analytic ways that help you to explain and advise what the model recognized in terms of human understanding. That means, for example, a shape of a tumor or calcification is a concept that can tell you if the model is confident in making its decisions. Now, practically, what can you do? I think at the very beginning, it's very helpful to combine the AA system with a reader. Maybe if you have other approaches like combining the reader with the system and working in parallel, and then at the end, you may have an AI system that is set ahead of the reader. It depends a bit on the questions that you want to solve. So in the evaluation phase, it's always wise to use an AI system and a reader together. For computer-aided detection, you want to find the confidence of the model and yourself to depict the lesion. And at the end, for the decision support, it may be that the AI system can be used to alarm you, and then the reader looks at the model. For us as clinicians, I think it's very important that we should be part of the model validations, that we also should have a closer look at the individual performance of the model. We should also strive for model monitoring in practice. I think this is the most important way to see how individual readers really perform if they are supported by the model in comparison to doing their analysis alone. And this also needs to be integrated into industrial standard. We need this kind of post-market surveillance. And of course, we need also retraining and calibration. So to sum up, the artificial intelligence identifies imaging patterns that we as humans frequently cannot detect. And therefore, we need to take care about standardization. We may use interpretability methods wherever possible to help us also and to increase our way of reasoning and to compare our findings with those of the models. And of course, at the end, the main course is to show the proof of outcome that needs to be demonstrated. Do we really need the model, or is it just a nice to have addition? We can do that by defining first our performance elements, secondly, by performing this kind of stepwise evaluation, looking first at the sequences, looking then on the reproducibility and the confidence of the model, and then at the end also look at the individual performance of the readers. We need to involve, of course, wherever possible, the evaluators that are independent and to cooperate with the manufacturers. But I think finally, something that we should not forget is that our business is related to uncertainty and that we always deal with probabilities. And therefore, I think it's very important also to say we as humans, we do not always make appropriate decisions. And so we should also allow the models at least to fail sometimes. Thank you for your attention.
Thank you, Roland Wiest, for your outstanding lecture. We have a couple of minutes for maybe just a question. Maybe Pinar, do you want to read one question, please?
Yes, thank you very much for this great overview. We have a first question by Eric Ranchard. Clinical AI application overall was the most successful in your department so far, and why? Is each application also systematically evaluated in the group? And what are the criteria for accepting an application in clinical practice? Is this always done prospectively or rather retrospectively?
Well, that's an interesting question. So I would say the analytics that we do on a model that is commercial is always retrospective. So I think if we just try to find out how good a model is performing, it's a bit of a philosophical way to ask if the model is good, because we cannot change it. But I think the selection for this kind of tools, at least in our institution, is mainly driven by the cases that we have. That means we have a lot of patients that have chronic disorders, chronic neurological disorders, and therefore our main interest was from the very beginning to look at longitudinal atrophy monitoring and also on the depiction of lesions. That's also why we built our own models that are not CE marked, but in order to compare the industrial standards with our own models. I think we needed to make our own, let's say, bad experiences also, because we were not aware of all these kind of really accuracy problems from the very beginning. So we did this kind of analytics retrospectively, and we learned retrospectively. That means we didn't have a too strong focus on the switches of different sequences. So for example, in our department, we have 4 different sequences for atrophy monitoring related to different questions of different clinics and hospitals. And we needed to standardize. But meanwhile, we achieved this kind of standardization. We also trained our technicians and we trained our team in order to be extra sensitive to this kind of parameters. But this was a process, and this was driven by retrospective failure analysis. And this is also what I would definitely recommend, to have a permanent failure analysis once you run your models.
Great, thank you for this elaborative response. The second question is by Ryan Geis. Models drift. What about monitoring for drift? Do you monitor output, input, or both?
Well, at the moment, we monitor the output of the model generally. We try we try to secure also that we always remain with the same protocols, with the same sequences, as good as we can do that. Of course, we are also, I think we are also prone to changes once the software updates happen in the scanner. But at the moment, we do primarily monitor the output.
And a same question, or another question by Ryan Geis, is from a technical practical approach. How do you record your monitoring by physicians, humans? Do you just have a metric, or disagree with the model? Or do you go deeper into why you disagree or agree, or something else?
Well, at the moment, I need to say it's rather simple. So it's the agreement and the disagreement. But I agree that this can be done much more fine-grained indeed.
But is that also the plan in which you also said we are mainly doing a retrospective analysis and improving by that? Do you also implement that already, or is it hard because also with scanner updates or software updates?
That's the main problem. So where we do not have full control over the parameter sets, we need to stick at least to for the CE mark tools, we need to stick to the methods that we get from the industry. Of course, we do this kind of retraining if we use our own tools. So there we are active.
Okay. Another question by Eric Ranchard is, how do you measure outcomes of AI results on the treatment and disease progress in the patients? For example, for brain atrophy, has any improvement in outcomes been made yet?
That's a bit of the problem. This is an excellent question. So because this exactly ends up in this point that I wanted to stress with the net benefit. of a technology. So do we bring the patient benefits if you just monitor the progression of atrophy? I would say for the moment that we at least we understand some things a bit better. That means during the COVID period, and we did this then again, so we monitored patients longitudinally where we had a lot of different recordings ahead of the COVID infection, and then we compared brain atrophy rates in patients who have been vaccinated, for example, in comparison to patients that have not been vaccinated. And at least we see this kind of differences. We see these changes in the entorhinal cortex, and we see also on the longitudinal step that patients do better with if they get vaccinated. So this is not a benefit for the individual patient, but there is a net benefit for the population, because you would advise your patients to get vaccinated in order to avoid this kind of atrophy. So these are the first outcomes, but I agree, especially for dementia patients at the moment, it's an open question. We will see what happens now with the new drugs on the market, if there is a change now, and if we really need to longitudinally monitor these patients. But I would assume that at least for the patients that are suffering from MS in the transition phase, from relapsing, remitting to chronic MS, we can apply this kind of NIDA-4 criteria, at least to inform our colleagues from neurology to have a closer look about the potential progression that is out of relapses. Yeah, and I think there I see definitely a role for that. But of course, these kind of outcome studies still need to be performed because the concept is rather new.
Thank you very much for this excellent answer.
Wonderful discussion in this time, and it will be wonderful to continue maybe for the next webinar about this topic. But now we will have just another last question. Maybe we have time, Pinar?
Yes, for sure. Another question by Remka is we are seeing significant issues with data drift, set drift. Sometimes even changing a machine's tube causes significant drift, or they update software on something, changes in the DICOM header, or how to use a filter which affects the machine learning accuracy. Do you monitor on a continuous basis or at some interval?
We do it at intervals, and I fully agree that this is an unsolved issue at the moment, because we have not so much control about these updates. And the only things that you can do there is just doing this kind of monitoring and retesting by applying, let's say, more sequences. That means repeat these sequences within one session or shortly behind, and also use maybe your colleagues from methods to lie to the scanner, and also to act as the phantoms in order to better identify this. But this is something that is unfortunately out of control, especially for tools that are not built in-house. So I think it's easier to address this for own developments, but it's another topic to talk about CE marks and the usage of this kind of tools beyond research. But I think there we are out of control, and that's the reason why we want also to get close in cooperation with industry, because this is the only way to go. Have a permanent quality assurance system in place to permanently, I think, also address this kind of questions together with the vendors, and also to alert the vendors. And this could be our task as clinical radiologists, to inform them if something's going out of reliability.
Mm-hmm.
Okay. Well, I noted that we have one last question by Eric Ranshep. I can read the last one. Do you think it's important to develop in-house apps to make them more usable in your practice?
Yeah, I can only say yes, of course, because I think that's what makes us as an institution visible. And of course, we do this for research, but it's as important also to compare the differences in the quantification between in-house developed tools that have been trained, at least in part, on our own data, and to see what's the differences, and also to see what's the reliability in the longitudinal measure. So the answer is yes. The problem is that we as universities, we are by no ways built to make CE marked processes. So the only chances that we have, and I come back to what I said before, the only chances that we have is to get in closer touch with industry and to work together.
Thank you. Also, Eric Ranchert answered as an excellent answer. So I maybe I think it's time to close, because we went over our time. So another time, thank you, Roland Wiest, for your outstanding presentation and to answer your questions. And for the last thought, it's now the time and the microphone to Pınar Yılmaz.
Thank you very much again for this great overview and discussion at the end, and to be our last presenter of the year, to close it with a great webinar session, again sponsored by Bayer. So thank you very much, and we hope we thank everyone who joined us as well for the great questions, and we hope to see you next year in 2023 again for a great webinar series. We have a lot of new things planned as well, so stay tuned. And see you all next year. So have a great Christmas and New Year wherever you are at the world. So yeah, it's a great applause for everyone for this great effort. Thank you.
It will be another great year with our society, and I hope everyone will join our webinar series also for next year. Thank you again, Ronald. Thank you, Pınar, and see you next time. Bye.
Bye.
Pleasure to be with you. Thank you very much.
Thank you.